Thank you, Beth. Ladies and gentlemen, thank you so much to the directors of this course for inviting me, and congratulations on such an incredible course, so informative and so wonderful. And to see all of you everywhere else, Nurse Tech Symposia are dwindling in the number of participants. It's wonderful to see this vibrant, amazing course here at Mount Sinai, and it's a testament to the work that you guys have done and the dedication that you have in making sure that all of our allied healthcare professionals are well educated and up to date with all of the important news. So this whole concept of short versus long duration of DAPT is a very sort of a hot, sexy topic, actually, because there's a lot of issues about yes, everyone needs antiplatelet therapies after you give them a drug-eluting stent, and obviously at the moment 99% of the patients leaving the cath lab are receiving a drug-eluting stent. The question is, for how long? Is it 3 months, 6 months, 12 months, forever? When do you stop the dual antiplatelet therapies safely? That's the big topic, and I'm here to kind of go through all of the data and give you my feelings about this. So as I said, antiplatelet agents are the cornerstone of therapy for not just stented patients, but also patients who present with an acute coronary syndromes, whether or not they receive a drug-eluting stent, but also, importantly, those patients who have peripheral vascular disease and coronary disease with or without PCI. It's an important piece and part of their treatment modality. We know that dual antiplatelet therapy reduces death, MI, CVA, ischemic events, but we also know that we have sort of a double-edged sword with them, because these are elderly patients, and placement of these patients on these therapies exposes them to the risk of bleeding. So the big question comes, how long should they be on it? And this has been the big dilemma for the last year and a half, 2 years now. And so in order to take you through this, I'm going to go through these 4 different concepts. First is the safety and efficacy of prolonging dual antiplatelet therapies, this trade-off between thrombotic and bleeding events, the important use of the new generation DES, how great the current metallic stents are, what we need to do with our bioresorbable scaffold patients, the few that did receive bioresorbable scaffolds, and very importantly, the fact that we really do have to kind of take this into consideration, not one size fits all. And that's a great thing, because you, as our allied healthcare professionals, the ones who really are exposed to these patients more than anyone, including the physicians actually, are the ones who are out there knowing about the socioeconomic status and the health care of those patients. So let's get through it. Safety and efficacy of prolonged dual antiplatelet therapies. There's a lot of trials trying to figure out short versus long, long versus longer. And unfortunately, not one trial gives you the answer. And that's what happens when these trials don't have the power, or there are small numbers of patients. What we do is we perform meta-analyses. We lump them all together and we try to see what really happens. And in green are those that have short duration, and in red are those who have a little bit longer duration. And we put all of that data together, and what we came up with is this meta-analysis that was published in JACC. A lot of it was driven by this trial. The trial is the DAPT study. This was published in the New England Journal of Medicine. And I think it's really important, especially for you guys, because you see these patients a year out of their drug-eluting stent. And the big question was, for a patient who tolerated dual antiplatelet therapies for an entire year without a bleeding or an ischemic event, is there a role in prolonging dual antiplatelet therapies beyond a year? That's the only question the DAPT study answers. And I think it's important, because what they did is they weeded out all the patients who had bleeding or ischemic events in the first year. So it really is only looking at those patients that comes after a year of tolerating DAPT, and now you have to make a decision, should I prolong or should I stop? Well, this is what happened. If you give them dual antiplatelet therapies beyond a year, you will reduce myocardial infarction, stent thrombosis, major adverse cardiovascular and cerebrovascular events, but you also expose them to a big risk of bleeding. Most of these myocardial infarctions were outside of the stent. It wasn't about the stent, it was outside. 55% of these MIs were outside of the stent. The bleeding was not without any kind of a big price. These are moderate severe bleedings. So for reducing ischemic events, we increase bleeding events. Now, what is the right thing to do? Well, that's why we needed the meta-analysis. We put all the data together, and there's no question that when you prolong dual antiplatelet therapies, you can and will reduce ischemic events. You will reduce myocardial infarction, you will reduce stent thrombosis. No question about that. But when you shorten the dual antiplatelet therapies, you will reduce bleeding. And you might even reduce all-cause mortality. And that was the big question. If reducing myocardial infarction is so good, why didn't these patients who received prolonged DAPT live longer? Perhaps the bleeding was more prevalent, and bleeding-related deaths has to be the answer here. And there's no question that that's the dilemma that we as clinicians and you as healthcare providers working with physicians have to make at the time when you see these patients. Well, what is that trade-off between bleeding and ischemic events? Well, in our meta-analysis, what we did is we did the calculation. We could do that in a meta-analysis. And so for every stent thrombosis that you prevent by prolonging dual antiplatelet therapies, you are causing a 2.1 extra clinically significant bleeds. So you have to decide which one is more important. And I think that's a really, really important question. But bleeding is important and it matters. And here's data from the ADAPT DES study where we actually looked at post-hospital discharge bleeding. When patients bleed in the hospital, they're lucky because you nurses are around and you take care of them swiftly, quickly. You transfuse them, you make sure they get back onto their feet. But when bleeding occurs outside of the hospital and they end up in some other unknown hospital, things happen, bad things happen, like their dual antiplatelet therapies immediately get stopped. And for some reason, they don't start them back on statins. They don't give them beta blockers. We don't know why, but this is what happens. And in fact, bleeding is so important, out-of-hospital bleeding is so important, that the hazard of dying is 5 times higher than if you don't have bleeding outside of the hospital. It's also even worse than having a post-discharge myocardial infarction. So we really do have to see and figure out who's going to bleed and who's not. And I have some tools for you. Well, let me, before giving you the tools, tell you that the new generation DES has made a very, very important impact in reducing ischemic events. Thank goodness that maybe we don't need it for the stent. We might need the dual antiplatelet therapies for events outside of the stent, but the stents have become so good and the stent thrombosis rates have become so rare that maybe we can shorten the duration of dual antiplatelet therapies. We certainly don't need 12 whole months mandatory. And in fact, when we looked at our meta-analysis, we found that actually there was a lot of attenuation in the stent thrombosis rates if you looked at a second generation DES. So the benefit wasn't that much. And in that same DAPT study, when we looked at the everolimus eluting stents, which is the stents that we put in our patients, in that group, about half of them received an everolimus eluting stent. In fact, if you prolong DAPT, you did reduce stent thrombosis, but not to the degree that you did with the first generation DES, but mortality was worse. Now it's statistically significant. Maybe we don't need to prolong it if you are giving patients everolimus eluting stents. Certainly is something to think about. Does one size fit all? Well, that absolutely, everyone knows the answer to that. I wish it did. I could still be wearing size 3 clothes when I was a young girl. One size does not fit all. We have to make important clinical judgments on our patients. And how we do this is by comprehensive clinical evaluation of looking at their ischemic and bleeding risk, but much more important is the clinical profile of that patient. And that's when we need to dig deeper, spend time with the patient, understand their socioeconomic status, whether or not there's malignancy or smoking, whether there's expected adherence. You can't imagine how important is that discharge class that you guys do before any patient goes home. to make sure that they adhere to not just their dual antiplatelet therapies, but also to their lipid lowering reduction, lipid reduction therapies, as well as diabetes management, hypertension, etc. So this is really, really important. And then, of course, we take all of those things into account. And then we, as clinicians, have to say, what are we really doing? Are we treating the stent, or are we treating the patient? And I hope the answer is that you're treating the patient. We are not treating the stent. We're really treating the patient. A stent is just a tiny little piece that is put into the patient's arteries. The patient's arteries are really all over the place, into the brain, down the legs, in the kidneys, everywhere. So we do have to think about the patient. And in fact, there is some evidence that the higher risk the patient is, there is a benefit to prolonging dual antiplatelet therapies. And this is from the Charisma study, where they looked at the patients. The trial was negative, but if you looked at for secondary prevention, dual antiplatelet therapies were very, very important, not just for PCI patients, but anybody with a prior coronary disease. So very important. And it was for that reason that the Pegasus study was taken on. Here with ticagrelor at 2 different doses, 60 and 90 milligrams BID versus placebo, and the background of aspirin therapy. And in fact, in this large almost 22,000 patient study, they showed a reduction of death, MI, and stroke, significant reduction, but they also showed more bleeding, almost to the same degree of reducing MI, which brings us back again to say, well, how can I find the patient who's going to benefit with reducing their death, MI, and stroke rates without giving them a bleeding hazard? Can I do this? Well, the answer is yes. There are several algorithms. Here's one I put together for this chapter in The Lancet with our colleagues. We said, look at the patients who received the PCI, think about that mandatory period of DAPT, and think about how long or short it's going to be according to the patient's risk. Make sure you get a good result at the time of PCI. Make sure you educate them. Make sure you give them the good instructions. And then once that mandatory period, whether it's 3, 6, or 12 months for whatever the patient is getting, is over, then you need to assess that patient again for the risk of bleeding, risk of ischemia, and then, of course, managing them accordingly, whether or not you would prolong the dual antiplatelet therapies. But there are even smarter ways of doing that. One way is to use the DAPT score from the DAPT study. Remember, this score will work at 1 year after full toleration of dual antiplatelet therapies, and you can put this equation up, and it's very, very easy. It's in the App Store, and you get an integer score, and you can see if the DAPT score is greater than 2, you're at a high risk of ischemic complications, and you won't bleed as much with prolonged DAPT. You'll get a good result. Conversely, if it's a low DAPT score, you better think about it and not, you'll expose them to too much harm of bleeding. So that's a great score. We also developed a score here at Mount Sinai using the Paris study from our work with Dr. Usman Baber and myself from the Paris study. We looked at it at the time of PCI. That's an important question to ask at the time of PCI, and we did do that. And for every patient, you get a score for bleeding and a score for ischemia, and then you plot it on here, and you see where the patient fits for the bleeding risk, and you put them into this platform, and you see whether there's benefit or harm. You plot it out, and it really is a very, very simple, easy risk calculator that's online as well. There's also the precise DAPT risk, which is also put together by 14,000 patients in large clinical studies. Here, they say if you figure out a patient's bleeding risk by using the precise DAPT, those are the patients who, if they have a high bleeding risk, you should never consider a prolonged DAPT on those patients. It's a very, very interesting parameter. Importantly, you should know that these risk scores haven't been fully validated, but they are tools that you can use online and calculate whether or not a patient should get a prolonged DAPT or not. Another important consideration is the anatomic variability here. If you have a patient who had a long lesion in a small vessel with bifurcation, multiple stents, well, you better believe that this patient needs prolonged DAPT, and you better not put it in all those stents in a high bleeding risk patient, because you will need to expose them to the harm of prolonged DAPT because of the number of stents you've put in there. So again, it's a very, very important risk calculator to look at the patient-related factors, the anatomic-related factors, and the stent-related factors, which come into play when we make those decisions. It is also important to note that more and more we're going through, longer is not necessarily better. And we do need to pay attention to the high bleeding risk patients. So many of them come in on oral anticoagulants now, novel oral anticoagulants. What do we do with those patients? We certainly can't expose them to a prolonged duration of DAPT. The new stent technologies are promising to show with the biodegradable polymers that maybe they can have an important reduction in their length of need for dual antiplatelet therapies. This is with the Synergy stent, and I'm proud to say that I will be the lead national principal investigator for the Abbott Zion stent, looking at just 3 months of dual antiplatelet therapies in patients with high bleeding risk. And we're outside of the United States, we're even going to go as short as 1 month in those high bleeding risk patients. And we're going to look at that because we do believe very, very strongly that the Zion stent is performing extremely well with very, very low stent thrombosis rates. Where did this all come from? It came from this particular study, the Freedom Stent, which is actually a stent that has etchings and surface modification, and so there's no polymer. The drug is embedded into these surface modified surface of the stent in the luminal side, as you can see here. And in the leaders-free trial, 2,500 patients were randomized to bare metal stent versus this stent with 1 month of dual antiplatelet therapies. And you know what happened? The patients who received the drug-coated stent, of course, had a lower target lesion revascularization. Drug-coated stents reduce restenosis, and sure enough, it did in this patient population after 1 month of DAPT. But look at what happened to death MI and stent thrombosis. So in fact, after this study, when bare metal stents were being given to all of the high bleeding risk patients, bare metal stents are no longer at all being given to patients, and in fact, it's really drug-eluting stents for all. What do we do with bioresorbable scaffolds? Well, I can tell you one thing. We absolutely have no idea. The optimal duration is unknown. The trials right now have given 12 months of dual antiplatelet therapy. We only have a first-generation BVS, and you all know that there's a signal. And in fact, here at Mount Sinai, we haven't been placing bioresorbable scaffolds. They're still on the market. We just have not been using them until there's more data which is promising to come out. So the optimal duration is unknown. I recommend to anyone who has a bioresorbable scaffold, and if you come across those patients, if they're tolerating their dual antiplatelet therapies, please keep them on it. I would not stop it until we have more data. It's important for you to know that our guidelines have been based on evidence review. And I'm proud to say that Usman Balber, who's a member of our cath lab, was part of this important committee that basically looked at all of the evidence and made the recommendations to us on the guideline committee. And the guideline committee came out with these recommendations. So it's actually simple. It looks very, very complicated. If you have an acute coronary syndrome, it has nothing to do with what you got, whether you got a stent or a bypass or medical management. You are getting 12 months of dual antiplatelet therapies unless you have a high bleeding risk. Very simple. In stable ischemic heart disease, it's a little bit different. If a bare metal stent, it's 1 month. Don't ask me, because I tell you the stent thrombosis rates are better for drug-eluting stents, the second generation DES, than they are for bare metal stents. But be that as it may, it's still 1 month. We shortened the duration of DAPT down from 12 months mandatory now down to 6 months. And for those patients at high bleeding risk, you can even go shorter to 3 months. So it's a very, very interesting moving target, and we're getting a lot more data out of this. Importantly, one of the things we're doing is, can we drop aspirin? Why are we stopping when we go to a single antiplatelet therapy? Why are we stopping the clopidogrel or the ticagrelor? Why not keep them on that and get rid of the stomach sluffer, the aspirin, that is bringing the patients in with GI bleeds and having gastrointestinal issues? We're doing that in 9,000 patients in the Twilight study. We've already randomized 6,000 patients, and enrolled 6,000 and randomized close to 4,000 patients in this prospective randomized double-blind controlled study. I'm very, very proud that we are running that. It is important to note that with the Biomatrix family of stents, they have done this in 16,000 patients. 1 month of aspirin ticagrelor, go into ticagrelor alone therapy versus aspirin clopidogrel for a standard of care. So finally, in conclusion, after a drug-eluting stent, if you prolong DAPT, you're going to reduce stent thrombosis and myocardial infarction and ischemic events. But you're also going to increase bleeding and maybe mortality. So you better get smart about figuring out who's going to benefit. And you can use these risk calculators to make those important choices. The new generation DES are helping you. They're on your side. They're really good in reducing ischemic events. Stent thrombosis is now a rare event. We used to see it in the cath lab a lot. We don't anymore. So on that front, we're ahead of the game. But let's not ration patients and say everybody should get a short duration of DAPT. Some of these patients, the high-risk diabetic patient, the one who presents with an acute coronary syndrome, the patient who has multiple stents and multiple coronary disease and diffuse disease everywhere and peripheral vascular disease, but is at a low risk for bleeding, may benefit, in fact, do very well with a prolonged dual antiplatelet therapies. So we need to use our brain and figure that out when we're seeing these patients and using the risk calculators and the patient assessment and understanding what's going on at home, who's taking care of you, can you afford the medication, will you adhere to these medications, and understand better how to do that. And then finally, I think one of the biggest and most exciting part is aspirin withdrawal, and we here at Mount Sinai, this institution is the sponsor of one of the most important studies that will, for the first time, withdraw aspirin from the armamentarium of treatment of patients with complex coronary disease in an effort to improve their bleeding risk without changing their ischemic complications like myocardial infarction and stent thrombosis. So thank you for your attention. All the answers aren't there. The great thing is that we as doctors need you as our allied healthcare professionals to help us, because you're the ones who really end up talking to the patients much more than we do. So thank you for that, and thank you.